hospitalist doctor covers the gap in care from primary care doctor to hospital or from emergency room back to primary care. Hospitalist care, transition and benefits. Tonight, On Call with the Prairie Doc.
Health information based on science, built on trust. I'm your Prairie Doc host, Dr. Jill Kruse, and tonight we will be talking about hospitalist care and answering viewer questions. According to the dictionary, a hospitalist is a physician dedicated to the care of patients who are hospitalized. The term hospitalist first appeared in print in 1996 and is derived from hospital, which traces back to the medieval Latin hospitali, meaning hospice or guest house. Hospitalists play a vital role in ensuring that patients receive high-quality, coordinated care throughout their hospital stay. These professionals collaborate closely with a range of healthcare providers, including specialists, nurses, and pharmacists to deliver seamless care for their patients. To do this effectively, hospitalists must possess a broad knowledge base to address the diverse health conditions that may require hospitalization. Tonight, we will discuss hospitalist care and take viewer questions. Thank you for joining our discussion. This evening, we are joined in the studio by Dr. Catherine Leadabrand from Brookings Health System and via Zoom, Dr. Clarissa Barnes from Avera McKennan Hospital and University Health Center. Welcome and thank you so much for joining us this evening. Dr. Leadabrand, could you please share a little bit more about your background and what inspired you to work as a hospitalist?
I graduated in medical school in 1995, and at that time, and finished my residency in '99, and then went into just a standard traditional general internal medicine practice. So I saw adult patients both in the clinic and at the hospital, and as my practice grew and I had a young family, it got a little bit challenging. Medicine became more complex, more fast-paced. I'd have maybe sometimes a whole clinic, and it would get a lot busy. I might have patients in the hospital that I'd seen before clinic, but over the lunch hour, maybe someone had trouble. I'd have to run over there or even cancel my afternoon clinic if someone really was unstable. And it was really hard to choose because I loved both, but I knew we were kind of getting to the point, as were many other doctors in our group, that we knew that we needed to divide the labor a little bit. And I'd always really felt comfortable in the hospital. Internal medicine residencies, a lot of it is in the hospital, so I kind of like the fast pace and being able to never know kind of what you're going to get and be able to check back on the patients later in the day. So that's when I made that choice.
Excellent. All right. Well, Dr. Barnes, tell us a little bit about your background, specialty, how you came to be a hospitalist.
So I'm an internist too. My first clinical job was also traditional internal medicine. I had a clinic and I would go across the street and I would see my patients in the hospital. I started doing sort of more outpatient work at one point, but was still doing hospital work. And I also found myself at a point career-wise where you see, you want to do both. I mean, a lot of people are drawn to internal medicine because they love taking care of adults. They love chronic conditions. I mean, they don't love chronic conditions, but you love taking care of adults and helping people navigate like their multiple chronic conditions and helping them sort of navigate all of those, complex medical issues and partnering with them. But knowing that it is difficult, the sort of profession in general was moving towards a direction that made it more difficult to continue to do both. And I was also simultaneously starting to navigate an increasing amount of administrative time. Like I was starting to do more and more administrative work as well, and found that I couldn't continue to have a clinic and a hospital practice and administrative work. And so I had to pick one to sort of go first, and it was I had to let go of clinic first and became sort of a full-time hospitalist and picked the administrative work with my hospital medicine first as sort of the first decision point in my career. which felt really natural, because similarly, I really enjoyed the idea of sort of taking care of people that were the most acute as the type of medicine I liked the best.
Yep, and I'm also sitting here as the hospitalist, but the family medicine, so a little bit more unusual to have a family medicine doctor as a hospitalist, but not unheard of. I know most are internal medicine, but kind of the same thing, started full practice, doing inpatient, outpatient, covering call. And I did notice when I first came to Brookings 13 years ago, that when I was on call for the hospital and doing admissions, in the 24 hours that I was on call, I would average 0 to 2 admissions. If I had more than 2 admissions, I would say it was a busy day in that 24-hour period. Now, as a hospitalist doing inpatient, I could have 2 admissions before noon. And it's not unusual to have 6 admissions in a 12-hour shift and another 3 or 4 admissions overnight. So that volume, to ask someone who's working in the clinic to try to do both, I don't think that would be feasible, logistically possible with just that rise in volume. And it happened so slowly over that period of time. But now when I look back, I'm like, wow, I remember thinking, more than 2 admissions, and oh, that was a rough night. And I'm like, oh, if I only have 2 admissions on a hospitalist shift, that was a light day. And that's only 12 hours, where we used to do 24 hours of coverage. So I think that really shows, as our population grows, as our population ages, and people are getting sicker and dealing with more chronic illnesses as they're living longer, that we definitely need this role of someone who can give their full attention to patients in the hospital and not be split between trying to do both outpatient clinic and inpatient medicine with your sickest patients.
I think the other thing I was just going to say really changed was people used to stay in the hospital a lot longer. People who had a knee replacement would be there 3 days. And now people often come in and they go home the next day, and you have such a rapid turnover that the clinic docs can't get over. The hospital needs those beds for other sick people or people, and if you're in the clinic, you couldn't come over to discharge them soon enough.
But this is part of the reason why we're able to do that.
Yeah, exactly.
Physicians who are constantly monitoring and making changes and helping to get people better sooner. When you see a patient in the morning and you sort of make a plan and you say, okay, I'll see you tomorrow, and then kind of go over to clinic, and you can't really get back to it, because you've got 16, 20 people that you have to focus your attention on. Yeah, people do tend to stay in the hospital longer because you're not focusing on that at that point, which I think is why we have seen better length of stay or better care outcomes for people when you have physicians stationed in the hospital, sort of really only focusing on those patients without that split attention.
Exactly. Yeah. Well, before we get too far into our conversation, we invite you, our audience, to submit your questions for tonight's discussion about hospitalist care. Viewers can contact us 3 ways. Call 1-888-376-6225, send an email to ask@prairiedoc.org, or ask on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible, given the time available. Sometimes we receive more questions than we can cover, and we apologize if we do not get to your question. Your question will remain anonymous, and no information is saved. Viewers can leave their name, email, or phone number to be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie, but it is not required to submit a question. The winner will be drawn and announced at the end of this program. So yes, definitely, I think there's been a big shift. I hadn't even really heard of a hospitalist when I was in training. Maybe at a super big hospital, you would hear about it, but it was very much, you were a doctor and you saw people in clinic and you saw people in the hospital. And then towards the, I think I was out of training for a few years, and where I trained at in Baraboo, they talked about, we're getting a hospitalist program. I'm like, Hospital, what is that? That just seems so weird. You want someone else to take care of your patients when you're in the hospital? Are you sure? Is this going to work? How is this going to work? It was such a foreign concept to us as doctors, but now I think it's really taken hold, and it makes a lot of sense.
Yeah. Of course, it'd be nice to have your own doctor the whole time, but it's, again, that's just not practically possible anymore.
Yes. So I think we should probably answer, so what types of medical professionals can serve as hospitalists? Dr. Barnes, who do you have, what specialties are serving as hospitalists?
I mean, for adults at our hospital, everybody's an internist. I know other hospitalists like you are family practice doctors taking care of adults. The emerging trend is now we're seeing it really move into the kids. Right now we're seeing pediatricians and pediatric hospitalists, or even OB-GYNs are getting in on the hospitalist game, so to speak. So you're seeing sort of other specialties sort of starting to sort of specialize and say we're going to have somebody who's in the hospital all the time instead of having people sort of split their attention. So who knows what will come next.
Yeah, I have a OB-GYN friend who wants to be a laborist and just deliver babies. She's like, that's what I love. That's what I want to do all day, every day, is just deliver babies.
And one of my best friends is becoming a surgicalist. So she's a surgeon who stays at the hospital and can respond and do all the inpatient operations. Yep.
Trendsetters.
Yeah. So, I mean, it's kind of a interesting term because it's not a specialty per se. I mean, there's a few fellowships out there for people that want to get more training in that, but you don't need to be, you're not board certified as a hospitalist. You're board certified as internal medicine or family medicine or whatever your specialty is there. So I guess one of the questions is kind of how does the role of hospitalist differ from a traditional physician? Is it Kathy?
So well, again, it's more kind of the place that you are. So you start with the patient often in the ER, and you're admitting them. You take care of them through their hospital stay, and then you discharge them back to the care of their primary provider, physician or nurse practitioner or PA. So I guess mostly it's the place. Some of it too is like hospitalists are often very involved in sort of the efficiency or the processes in the hospital. So a lot are involved in not just looking at the individual patient, but looking broadly at the population. Are we doing the best practices to reduce infections in the hospital, or try to reduce blood clots, or and then there's a huge team approach to try to secure the right, a big part is discharge planning and trying to assess and make decisions on where is the best place for the person to be discharged to after they leave. Many times they need rehabilitation, or sometimes need hospice, so home health. So we're working always, it's a real team approach, which is seen at clinics too, but I think we're really, I think there's more interactions during the day with the whole team in the hospital setting.
All right. So it says kind of when and why did the hospitalist specialty emerge? And like I said, apparently 1996 is when that was first mentioned. I think I've noticed it seems like it started in bigger hospitals, and then it's kind of slowly trickled down to the medium size, and now I've seen even critical access hospitals. The smallest of our hospitals have people that basically serve as hospitalists and just take care of inpatient there. So now it doesn't seem to be very size dependent.
Well, and there are even e-hospitalists, or there's a subset of hospitalists, nocturnists, that work nights, and in some places, smaller places, they have people that are doing that by Zoom. You know, they have, you can listen to their heart, you can transmit their heart sounds with an electronic stethoscope, and someone, you know, in another state or even sometimes another country can, you know, look at, help make decisions, and so. kind of the possibility. Everyone has to, I think it's just a matter, everyone does what they can to make sure their patients are getting the care they need, even in places where there just aren't physical doctors there all the time. So.
Yeah. Well, Dr. Barnes, here's a question from a viewer. Do hospitalists discuss prescriptions with other specialties like cardiology or nephrology, or are those specialists aware?
Ooh, that's a great question. I mean, you should be. I mean, that's the point. I mean, I would consider the hospitalist to be sort of the captain of the team, so to speak, depending on the way your hospital works. I mean, some hospitals will allow the subspecialist to write the orders directly, at which point I would hope there would be some sort of communication around the time that they're putting the orders in. Some hospitals will make you actually go to the hospitalist before you and have them put the orders in for you, which means they have to talk to you first. But there should be good communication. Sometimes they'll do it first, and then you'll have to sort of you find out after they've done it. So it's not always immediate, if that makes sense. But yeah, there's usually discussion. The problem is that sometimes not everybody agrees, right? Sometimes the cardiologist wants one thing and the nephrologist wants another. And sometimes the hospitalist is then the broker, the person trying to sort of get the team members to come together and figure out, well, what are we going to do? Because we can't have two different specialists having a sort of exact opposite opinions about what we should do with the medications. We can't have one person putting fluid in and one person taking fluid out, because that doesn't really lead to a good outcome for the patient. That actually is just wasting everyone's time. So you sometimes have to do some negotiating and be that leader and advocate for the patient.
Yeah, I definitely think as hospitalists, our role is to be kind of the overall person who's managing this, kind of the quarterback, and seeing what everyone's doing and does this make sense for the patient, because the specialist will just focus on their organ, and we have to see how do all these organs work together and make sure that we're making the most sense in how we're treating.
How the organs work together, and also what is the social situation for the patient. Maybe just because we can treat this cancer, is that what the patient wants? Is that what what is in their goal of care? And so that's a big part too. And
right.
And
what does the
one
patient
of the
want?
Yeah, and sometimes we can be the voice to that, because some patients are kind of scared to contradict what a specialist has recommended to them and say, I don't want that, or I never picked up that prescription, and so we can say, oh, okay, well, was there a reason? I couldn't afford it, or, I'm afraid of the side effect, or I read the label and I threw it away. So I think we do have that gift of time where we can really interact with those people, and then, sometimes be that bridge between the specialists and the patient to kind of explain some of the things that are going on. And I know if I admit someone for, exacerbation of their lung, and I know they've got a regular cardiologist and they saw them last month, I'll call them up and say, hey, just so you know, this patient was admitted. I saw you were, you saw them in clinic last month, you started this new medication, they're having these side effects, or you started it and it's working but not enough and we're having a flare-up. Is there anything you would want to do to tweak, or what do you suggest I do going forward?
Yeah.
So, all right. Well, Darren Willardson serves as the Vice President of Provider Relations and Strategic Partnerships, as well as a hospitalist for Avera eCare, a leading telehealth company. Avera eCare's innovative technology is utilized in various settings, including clinics, schools, and even within police vehicles. Prairie Doc recently interviewed Willardson to discuss these developments in telehealth.
I am a hospitalist or internal medicine physician by trade, and so I do a few different things here. Normally I can see patients on the video monitors and via telehealth as an internal medicine physician hospitalist. I also serve as the Vice President of Physician Relations and Strategic Partnerships here at Avera, doing contracting throughout the nation for the telehealth networking.
Avera serves both inpatient and outpatient clinics. They also support critical care in hospitals and school health.
We're in the back of ambulances, seeing patients as they're being transported to or from hospitals. We're also in police cars for crisis care and behavioral health. So really anywhere where healthcare is needed, we try to be available.
There are several benefits of telehealth and being a hospitalist.
For one, it can match a provider up with a patient no matter where that patient is at and no matter where that provider is at. So sometimes in small communities you don't have access to the subspecialists or some of those specialty people, and so it'll provide them there in those areas where the need may be greater because of supply and demand. And so, again, in ambulances, in transport, to have a physician in that ambulance is really something we hadn't had before telehealth came about. And so with the technology of satellite communication and being able to have the telemedicine, the tele part of it, wherever you're at, this allowed Develop to provide those providers wherever the need is.
Well, I think I love Avera eCare. We use some of their resources in the hospital for their ICU, but I just think it's amazing that we're using this technology that was kind of started here in Sioux Falls and then is based there and really has changed how we think about getting care to people in remote locations.
Yeah.
So, well, we've got more questions from viewers. When a patient is in the hospital and the doctor is working and they contact the primary care doctor, how does the hospitalist collaborate with the primary care physician to take care of the patient? So, Dr. Barnes, you want to talk about how you collaborate with a primary care doctor?
Sometimes it's hard, to be honest, right? Because you're working in the hospital and your schedule in the hospital is flexible because you're taking care of patients and you're just doing what you need to do. But the doctor in the clinic has a full day's worth of patients that they see and they've got a schedule. So sometimes you're trying to catch people in between patients when you really need to talk to them. So sometimes, the schedules don't line up. And that makes it tricky, but we have lots of other communication tools, especially since our EMRs are so integrated. So sometimes you're sending people like messages through the EMR. Sometimes if you're in the same system, you can send them an email. Sometimes you're leaving a message with their nurse. And then sometimes it just depends on what the question is. Sometimes, if it's a simple thing that they're there for, sometimes the communication is you just send them a copy of your note. You're like, look, I'm seeing this patient. I don't necessarily have a question for them, but I'll just send them a copy of what I'm doing for this patient so that they know that this patient was here and I'm taking care of them. But I don't necessarily need any response from them immediately today because, I'm just taking care of pneumonia and everybody sort of agrees on what the right thing to do is here. And if they have questions, they always know how to find me too. Because that's the other thing is that they also know how to find me, and certainly they've done that if they have questions about what I'm doing.
Yep. It's definitely a two-way communication.
Yeah.
So
and they get notified when I don't know about your EMR or electronic medical record, but it notifies our doctors when their patient is admitted. They can they follow along, and I think pretty soon most everyone will be on the same sort of computer system, and we'll be able to see really what's going on at all the 3 areas in this area. So.
So Doug from Sioux Falls asks how hospitalist care is handled by insurance and how they collaborate with your primary care provider. So the insurance question, I always say that's above my pay grade. It's enough to know the medicine. I don't always understand the billing and coding aspect of it.
Yeah, I feel like...
I don't know that it's such an issue actually in our state because most of the hospitals in our state, the hospitalists are part of the hospital that you're in. So if you're fine with the hospital you're in, you're also fine with the hospitalist that you're in.
Yep, because we're employees of the hospital. So if your insurance is accepted by the hospital, the doctor. Whereas I know sometimes it'll be in bigger cities, the anesthesiologist is a private group and they're contracted and they might take different insurances than the hospital. But as hospitalists, we're generally hospital employees, so if your insurance is covered by the hospital, it should be a non-issue.
Right, so if you're coming to Avera McKennan, if you're going to be okay going to Avera McKennan, like the docs are all, the hospitalists are also Avera McKennan physicians, so you're fine either way.
We will say that we do, some parts of our day are we advocate for our patients, though some insurance companies don't always cover patients being in the hospital, you know, or at a certain level of billing. And so we have people that really watch that, and then we often, if we don't think that was fair, we will appeal, or we will talk to them, try to make a case. This is why they needed to be here. This is what we were doing. And a lot of times they understand once they get more information, they realize, oh yeah, they did need to be. We'll cover it after all. So
yes, but yes, hospitalists are the most likely physicians in the hospital to be on the phone with, you know, your insurance company if there's an issue, if they don't think your, you know, inpatient stay should be covered, for sure.
Yep, we're going to fight for you and say, yes, we think they should be here, or we would have discharged them. We know they need to be in the hospital.
X, Y, and Z, I'm on the phone.
Yep, so, all right. Another caller asks, can I ask for a specific hospitalist when I'm in the hospital? Oh, Brookings, no. It's me or Dr. Leadabrand, but we're not on at the same time.
So, yeah.
Most of the time.
Yeah, or Dr. Chowdhury.
Or Dr.
Our
Chowdhury,
wonderful partner too, so.
Yeah, so we can't. I know that's not anything. I don't know in the bigger hospitals.
Not really. I mean, it's pretty much, it is what it is. It's based on where you are. I mean, it can the location of your bed is what you're getting.
It can be tough sometimes because on occasion I know Dr. Chowdhury, we've all had to sometimes take care of our own family members, and that's kind of tough when you're the only one. But a lot of times people make adjustments. Usually there's someone who can help out, and then we work with some really wonderful APPs or advanced practice providers, that nurse practitioners, PAs that also work alongside us for part of the day at least, most days, not all. So we can kind of divide the care that way.
Here's another question. A person said they were in the hospital, and while there, the hospitalist changed how their condition was being treated. Should they discuss that with their PCP now that they're out of the hospital? Absolutely.
Yeah, and moreover, though, I think it's important if we do change a medicine that they've been on, we kind of try to document why we did that.
Yes.
Because the PCP knows them maybe better, knows them the best.
Yep. And we always send a discharge summary where we kind of summarize everything that happens, and I'll put in bold, underline, highlight, I changed this medication from this dose to this dose, or I stopped this and started that, and this is why. So they understand why that happened.
I think we've all been primary care physicians. I know I've certainly been in the position where I have carefully crafted this regimen over a period of time, and then I send somebody to the hospital, and then they come home on something else, and you're like, no, I took so much time to make this, and then it comes back and it's different. So you do appreciate at least the rationale about why you do things.
So, and if what they were on previously worked better, maybe it was just you were in the hospital, you were sick, that kind of threw everything off, and now that you're feeling better, you can go back on your regular. So, and that's why we generally will have someone follow up with their primary care doctor after they're discharged within a week to say, hey, how are you doing? Are any of these changes working, better, worse, same? This is when that should be discussed. So, more questions here. Is it easier for our clinic to have hospitalists in the community, and do the doctors from the clinic still make rounds when there's a hospitalist in the local hospital?
Most of them don't make rounds, or they don't round. There are sometimes social visits, or if a patient's really, really struggling, maybe they're trying to make, I've had some where maybe they're struggling with an end of life, like they're trying to decide if they should do cancer treatment or not. And sometimes the best thing is just to say, hey, I talked to your doctor, or sometimes their doctor will come over and see them and talk with them, and that really is helpful. But again, they're so busy taking care of patients in the outpatient setting that they too just often don't have that time. So we're kind of their eyes and ears.
Yep. All right. Well, here's a question for Dr. Barnes. It said, Dr. Barnes says she treats adults in the hospital. Do hospitalists treat kids as well, or is that someone else?
Well, I mean, it depends on your primary specialty, right? So as an internist, I'm trained to treat adults. So I wouldn't go outside of that just because now I'm in the hospital, for example. So if a kid comes into the hospital and needs to be admitted, it would go to a pediatrician, or in our case, we have a pediatric hospitalist group. And so it would be one of them that would admit the kids on a different unit. So yeah, I don't treat children just because they happen to be in the hospital. I stick to sort of the 18 and above that I would, just because that's what I'm trained to do.
And I could, but for ease of scheduling, we keep it with 18 and above in Brookings, just because I could treat an 8-year-old, but you can't. So, yeah, and with our shifts, there's no guarantee that I would be still on when the
Right, in a mixed group, it would be confusing to have.
It would be hard. Can we admit them? Can we not? Who takes? That'd be hard. So here's a question I've gotten several times. Can I see a hospitalist I saw in the hospital, and if I like them more than my PCP, can I schedule a visit with them in the clinic?
And typically not.
No.
Nope. No.
It's always
it's nice when people ask, though. It is very sweet when they're like, "Oh, can I see you again?" And you're like, "No, you can't. Thank you. But we need to find you a different doctor, for when you leave."
Yeah. So.
But we all do. We sometimes get to know our patients that do come in a lot, so we do have some long-term relationships that way too.
Yeah.
So.
Yep. There's a question said, can a hospitalist discuss all of the treatment for patients when in the hospital? Well, that's, I would say yes.
We do.
We do.
But that's kind of the general view and trying to tie it all together.
Yep. A lot of times if someone is admitted for like a hip replacement or an orthopedic surgery, the surgeon will admit you, but then we will be consulted to take care of all of your diabetes, your high blood pressure, your sleep apnea, anything that's not related to the surgery, we will manage while you're in the hospital.
Yeah.
So, and here's a question, do hospitalists do surgeries? Dr. Barnes, do you do surgeries?
Oh, I do not. You do not want that.
Nope.
I'm still an internist. I am not a surgeon.
Yeah.
So, all right. Another question, are hospitalists on call 24 hours a day at the hospital?
Well, sometimes at our hospital, sometimes we are, or even longer sometimes. We get, typically if you do a long shift, you do get breaks to rest, but it just depends on the shift and the structure and how many patients are in the hospital typically.
Yep.
So
our typical shifts are 12 hours, but you could do a 24-hour shift. But there's always a hospitalist, at least at our hospital, someone who's there in the hospitalist role admitting patients.
Yeah, it really depends on how your hospital schedule is structured and also the size. I mean, when I worked in Pierre, I would regularly do 24 hours and that was fine. I would never do 24 hours now at McKennan.
Yeah, it just really depends on how busy it is. When you think of that long of a shift, there has to be time when you can sleep and eat and have a break. So, but there's always someone there who's responsible for the patients in the hospital if the nurses have a question or anything's going on. So
I maybe this isn't the place to say it, but one of the best things I like about it is when I was a physician, I'd see the patient just a snapshot in time with them at usually morning or afternoon. But boy, evening is a real different time, and people have problems that come up in the evening that you never maybe see or recognize during the day, like sundowning, getting confused, or things like that. And then families, you see more of the families that sometimes at later hours, and then you sometimes get a bigger picture of what their home social situation is, or maybe family members will share things. So that's one of I'm kind of a early bird and also a night owl, and it's really that's kind of a wonderful thing about the job too.
Yeah, excellent. Well, Prairie Doc recently had the opportunity to engage in a conversation with Alyssa Olson, a community health worker from the Brookings Health System. During this discussion, Alyssa shed light on the essential role of community health workers and the valuable contributions they make to our healthcare system.
Primary role of a community health worker is to support and help people. We work with people to address social determinants of health to improve their health and well-being.
To become a community health worker, one must complete training at an approved facility, then can be certified in your state.
You do not need any specific medical training to be a community health worker because we're not medical providers, we're public health workers. Some other qualifications and characteristics that are good for community health workers to have are being active listeners, having empathy, really having a deep desire to help people. It's also important to know the resources that a community offers. Also, typically community health workers live within the community with which they work. And then sometimes they also share similar life experiences as their patients, which make it easier to relate to a patient on a personal level.
Olson states there is nothing typical when it comes to tasks for a community health worker.
There's not really anything typical about community health work. We do a wide variety of tasks. It also can depend on if you work for a community-based organization or a healthcare facility. Some of the common tasks that all CHWs do are just providing that support to patients and addressing social determinants of health with them to improve their health and well-being. It's really based on need, so whatever the facility you work for needs and whatever the patients need depends on what tasks you perform.
Olson works with patients to ensure all their basic needs are met.
Well, have you guys had much interactions with the community health workers? I know I love ours in Brookings.
I totally, what a wonderful thing they started there, because again, we have the case managers in the hospital who are really trying to look at what the needs are when the patient goes home, and sometimes that is like they just don't know how to organize transportation, or they don't have resources for food money or prescription money or that sort of thing. So just kind of, or maybe they can't keep track of all the different appointments they have. So it's just a wonderful service.
Yes. All right. Well, another question is kind of what's the advantage of a hospitalist over a primary care doctor? Why are we having the hospitalist as opposed to their regular doctors coming in to see them? I think we've kind of touched on that a little bit. We kind of touched
on that, but yeah, but again, too, being right there. So like sometimes someone will suddenly faint or something, and before it would be, when I was in the clinic, they'd say, your patient fainted, someone tried to help them, now come and see them, and then I wouldn't, you'd get some of the story, but you wouldn't really know what went on necessarily. It's much better when you can rush right to be there right there within 3 minutes or so, or a minute, and you can kind of see it as it's happening and then really get a better idea of what caused this. And then follow up on them later in the day once they're doing fine back in their bed and with a good blood pressure.
Yeah, I think the nurses really like it more than the old way of having to call and trying to get a hold of the doctor. And I feel like I know the nurses so much better now than when I was just coming over doing rounds and then leaving. I didn't really know them, and now I can just hear Dr. Kruse, and I can, by the inflection, I know if I need to run to room 205 or if I need to, go over calmly to the nurse's station. Just by the how they say something, I'm like, oh, I know that this is an issue.
I mean, it's better also in terms of like all of the outcomes, right? I mean, I think it's motivated primarily because of patient care, even though I think it made a lot of patients like kind of irritated in the beginning because they were like, where's my regular doctor? You know what I mean? It was like, where's my doctor? Why aren't they here? But it really was motivated by the fact that by focusing on like, hey, if we get people who are really focusing on like, how do we make pneumonia outcomes better or heart failure outcomes better, and really focus on making, making those outcomes better, making sure people have fewer readmissions or die less or generally have better, you know what I mean? Like all of those quality outcomes, like, and we've shown that that's true. Like that's why we do it. Like there's a lot of extra nice benefits, right? Like the clinic docs don't get as many phone calls and get to focus on their clinic work, or, you know what I mean? Like there's nice extra bonuses too, but it was really the patient care, I think, that drove the primary.
Yeah. And here's a good question. How do hospitalists keep up to date with all the information needed since they have the possibility of treating all conditions every day?
That's a great question.
I'm studying every day. Every day I'm looking something up, reading something, learning something, trying to get better, see what the newest treatment is. And
we all, like many of us, listen to podcasts. We do continuing medical education, go to conferences, journals. And then a huge part, though, is the specialists. We have just wonderful specialists in our state, that are willing to give you their expertise, even a patient that's not in front of them, that they're not getting paid for. It's such a nice collaboration to everyone wants the patient to do better. So it's like they've been so open to, like, this is what's going on. Am I, just not necessarily telling you what to do with that exact patient, but am I kind of on the right track, or point you to the right place? And
I definitely talk with specialists a lot more now as a hospitalist than I did as a primary care doctor, because I didn't have the time.
Yep.
So, do hospitalists spend more time than a PCP on patient education since you only see them for a short time? I would say it depends on the day, and it depends on how many patients we have in the hospital.
How to quantify that? Like, I don't know how to count.
Well,
I don't either.
I do think, though, it's kind of nice, because if you try to do patient education on if we have someone in with, say, their heart isn't working, they have heart failure. The first day they're short of breath, they're full of fluid, or say they came into the clinic and they were swollen, and you try to find the problem, then educate them on the problem, and prescribe everything right in that visit. Whereas we have that liberty to, like, okay, when they're feeling better tomorrow, let's educate, or the nurses are educating too. So it's the outpatient may educate over a period of months or years. If it's an acute issue, we educate over days.
And maybe more, we maybe do more of the initial, oh my goodness, we just figured out you have heart failure, and this is the first time we've known this, more of the initial diagnosis sort of education that I used to do, and less of the this is the 50th time I've had to explain to you about what diabetic diet means, and what low, you know what I mean? Those things you have to do sort of over and over and over again.
Plus, we have the luxury of here's the dietitian, here's the diabetic educator, here's all these specialists that can help us with some of that sit-down teaching.
Yeah.
So, well, here's an email question. I was prescribed some medication after a hospital stay and need to refill it. Who do I ask? Do I call the hospitalist, or do I call my PCP?
PCP.
Ooh. Yes, call your regular doctor, please.
Yep.
Because your hospitalist is probably not even on service anymore. They're probably off, and the person you would call is probably a doctor who doesn't know you.
Yep. So definitely, I usually, if it's a new medication, I'll give a 1-month supply. That should get you should be seeing your doctor, your regular doctor, within a week of being out of the hospital. They should see that new medication, have it in your chart now when they do that medication reconciliation, and then they take over refills. So, yep. A caller asked, what happens when I'm discharged from the hospital and I have a question for the hospitalist about something they said during my time in the hospital?
That is a really good question, and I know it's really hard to reach us for the same reason Dr. Barnes said. We kind of have a policy well, first of all, when they get discharged, the pharmacist goes over the medications, then the nurse goes over the instructions, and we try to encourage them to let us know if there's anything doesn't make sense when they're going through that, if you have questions. But then if sometimes we're there 24 hours, they know that they can call up. And if we are off, I've had sometimes when I'm off where they got a question, the nurse gives me a call and said, hey, can you clarify this? That doesn't happen too often, because the PCPs do an awesome job. I mean, they know what's going on. They are great at explaining. I'm sure they have to do a lot of explaining sometimes at the follow-up visit, but they're very good at that too.
Yep. So here's another question. Is there a limit to the number of patients a hospitalist can see in a day or be in charge of? So that's very hospital dependent.
Like by law or like by practicality?
Yeah,
Yes.
I was gonna say, I don't think there's any laws.
No. So it's usually like a policy that your group has come up with of like, this is what we think the census should be to be sort of safe and effective. And then usually there's some sort of like buffer of like, well, if we really have to, we'll go up to this for sort of short-term,
Yeah, COVID kind of
crisis management.
COVID put everything out the window. It was like, we do what we have to do.
And the trick at our place is the staffing, because you know you have one person on, and you just, some days you may have half the patients you have, and then other days you may have double or triple. So it is hard for the hospitals to staff. I know that there's a lot of flexible, sometimes there's just a lot of tricks and problem solving in it, and that's why administration is kind of behind the scenes always trying to work on that, get the staffing there.
Yeah. So here's another great question. It said, lately I've been frustrated in the clinic because I feel rushed in my appointment. Do hospitalists have the same time constraints as your PCP has during your visit?
It depends, because sometimes we're trying to see patients and we might have 2 or even 3 people very ill down in the ER waiting to be admitted. But the good thing is if we only have a short period, often we can get back or circle back or spend more time at another time of the day or the next day. Yeah.
I always tell myself it's not 15-minute increments. I have 12 hours, and this is what I have to get done in that 12 hours, and I'm going to go from the most urgent to the least urgent. So I always start with my ICU patients, and if you're the last patient I'm seeing in the day, that's actually a good sign that you're really healthy and almost ready to go home. So, well, let's see. Caller asks, do hospitalists work in the ER, or are they there only when someone's being admitted to the hospital? So, Dr. Barnes, how often are you in the ER?
I mean, the way that we've got it structured, you're only going to the ER essentially to pick somebody up. But I've worked in other places where sometimes they would call hospitalists for actual consults. Like they would have us come down to see someone and give an opinion, and maybe not with the intention to admit people. But yeah, not generally with the way that, it works at McKennan currently. And certainly not just for, they don't call us down for fun.
Yeah, in Brookings, we'll go down to the emergency room, see the patient, do our initial exam. I always tell people, I'm just getting a baseline. I want to see where you are right now, and then if something changes, I have something to compare it to. So I want to know what your heart sounds like right now. I want to know what your lungs sound like right now. And that way I know what I'm monitoring for. Because the whole point of being in the hospital is to monitor, are you getting better? Are you getting worse? What's changing? And I don't know that if I don't have a baseline. And the easiest place to get all of that is down in the ER, because they've got all the equipment hanging up nicely on the wall. It's this nice, private. The nurses aren't coming in and out. You're not waiting for therapists to come in and out. I've got you just to myself.
Yeah, and sometimes I'll go down the ER to admit someone to our hospital, but after we get more information, we're down there, we see them, we realize they need something that we can't provide at our hospital. So there are times, just even if the ER doctor sometimes says they're getting admitted here, sometimes things change, or we figure out more things that maybe needed some bedside specialist input or some procedure that we don't do at our hospital. So.
All right. Well, we've got time for probably one more question, and I think this is a great one to round out. What lessons can healthcare systems learn from a successful hospitalist program? I think collaboration is the biggest thing. I think the hospitalists, we've really had to learn how to collaborate with all of the specialists, all of the nursing staff, the respiratory therapist staff, the physical therapy, occupational therapy, the case management. I think we've learned really the benefits of teamwork in a hospital.
I 100% agree. So,
Yeah. Dr. Barnes, any last thoughts?
Well, I mean, I think a fully functioning hospitalist group helps you uncover most of the structural or like problem areas actually in your hospital that touch sort of every other specialty. Like, oh, we don't have like this service on, you know, on the weekend, and that's really causing like a patient flow issue, or we can't do this and that's causing an issue. You know what I mean? Like, hospitalists help sort of ferret out problems and actually help solve them. And so like having hospitalists actually becomes sort of like the way that you solve a lot of hospital problems, because when you have primary care doctors coming in, seeing patients and leaving, like, you don't have sort of that same level of detection, I don't think, of sort of those system level problems. So I actually think it's the way you solve hospital level problems.
I think so. Yeah, we take a lot of ownership over what happens in our hospital. So 1 minute left. Any final thoughts, Dr. Leadabrand?
well, I just want to kind of emphasize again that we're a team. We're not like in our own silo here. We are kind of holding hands with the primary care docs and the specialists, and everyone's so crucial to the care of the patient. So,
Yeah. And obviously, we all love medicine, whether it's outpatient, inpatient, both. But I think definitely we had the calling to go from outpatient to inpatient, and I haven't looked back. I mean, I actually, this week I ran into a couple patients when I was shopping at Walmart, and they're like, "Oh, we missed you," and I said, "I missed you too, but you haven't liked me enough to come visit me at my new job," which is a good thing.
Yeah.
But every once in a while, I will see someone that I did take care of in the clinic, and they're in the hospital, and it's just such an honor to take care of them, see how they're doing with their primary care doctor that I handed them off to, and touch base and say, how are the kids, how are the grandkids, how's your life, how are you doing? And I am
because
so
it's
happy
such
to
a
see you
vulnerable
again.
time for them, being in the it's just so vulnerable, and when you can see, like, we don't always see that
Exactly.
the happy.
So beautiful way to. All right. Well, our winner is Stephanie. A book will be sent to you shortly. We'll be back after this.
Overwhelmed with the amount of information available? Not sure which sites to trust? Head to the Prairie Doc YouTube channel today to access all previous On Call with the Prairie Doc episodes. And make sure to join us most Thursdays on SDPB or streaming on our Prairie Doc Facebook page.
Thank you to our guests, Dr. Leadabrand and Dr. Barnes, for volunteering their time to help us learn more about what a hospitalist does and answering our viewers' questions. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, Threads, YouTube, and TikTok, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online. Listen to us on Prairie Doc Radio on SDPB Sundays at 6 a.m. and 1 p.m. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with the Prairie Doc, thanks for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people.
Health inequality is a pressing issue that manifests at various levels. These disparities reflect deep-seated social determinants of health. Health inequality, examining public health disparities by zip code. Next time on Call with the Prairie Doc.
My name is Jennifer May, and I serve on the Healing Words Foundation Board, the nonprofit that runs the Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,